diagnose a patient of spastic paraparesis. Before examining the patient, look for walking aids and look at the patient's shoes, especially noting ankle supports, or orthoses, and scuffing, which results from foot drop. This will provide an idea of patient disability. Look for an indwelling urinary catheter, which would suggest bladder involvement. Meanwhile, look for contractures. In chronic immobilized patients, there may be scars over the tendons, representing previous corrective surgery for contractures and deformities. In the next step of examination, remember, in the lower limbs, pyramidal weakness is weakness of flexors. That includes hip flexion, knee flexion, ankle dorsiflexion, and eversion. Now, for checking tone, roll each knee from side to side, looking for loss of the normal delay with which the foot follows the knee. Lift the knee from the couch, and looking for the foot to jump up off the couch. The patient needs to be warned first, and told to relax, and keep the leg floppy. Regarding reflexes, look for exaggerated contraction at the tested muscle. For example, quadriceps for knee jerk. Look to see if there is spread of contraction to other parts of the leg, or the opposite leg. That would suggest a pyramidal lesion. For example, an ankle jerk test may also cause hamstring contraction on both sides. Crossed adductors is also a useful sign of hyperreflexia. The adductor tendon is struck just above the medial aspect of the knee. It is normal if the same adductor contracts, but suggestive of a pyramidal lesion. If the opposite adductor contracts as well, suggesting impaired descending inhibition. As next step of examination, to test for ankle clonus, hold the knee in the flex position. Avoid testing for patellar clonus as this can cause pain. Further in examination, look for the extensor response. That might be evident as big toe extension, fanning of all toes, or involuntary contraction of leg flexors. In slight pyramidal disease, the extensor plantar response can be initially elicited on the dorsolateral part of the foot, Chaddock's maneuver. With increasing severity of pyramidal disease, the tensor plantar response may be elicited from the whole sole of the foot, and later beyond the foot. Oppenheim sign, extensor plantar response when the inner border of the tibia is pressed heavily. Gordon sign, extensor plantar response when the Achilles tendon is pinched. Next step is a sensory examination. In this patient with spastic paraparesis, the presence of a sensory level will help localize spinal cord lesions, as it will alert you to the possibility of spinal cord compression. Furthermore, certain patterns of sensory loss will help determine the underlying cause. Moreover, in patients with weak hip flexors or spasticity, heel shin testing to test coordination may be imprecise and unreliable. However, if the ataxia appears, more than can be explained by weakness, especially if there is worsening of tremor as the target is approached, for example heel approaching knee or ankle, it would suggest that there is an additional ataxic component. A more reliable indicator of ataxia is demonstration of cerebellar signs in the upper limbs, or eyes. It is important that a brief examination of the spine is conducted at the end of the examination. Look for tenderness, scars, and deformities. In patients who are ambulant, examine the gait. With bilateral spastic leg weakness, there will be a scissor gait. There may be a high steppage gait, indicating foot drop. When presenting the findings, it is important to mention the absence and presence of a sensory level. Possible to try to give a cause. In addition to sensory finding, in a patient with spastic paraparesis, the following feature can help to identify the underlying cause. Cerebellar signs, particularly in the upper limbs, fasciculations, upper limb involvement, wasting of the small muscles of the hands.